தான் யூஷுவலா இருப்பீங்க. நீங்க வீட்ல இருக்கீங்க. குட்.
இல்ல சார், அப்படியெல்லாம் இல்ல. அப்படியெல்லாம் இல்ல. அது போன வாரம் அந்த மாதிரி அமைஞ்சு போச்சு. என்னதான் பண்றது?
ஆமா. யூ ஆர் இன் a busy schedule.
ஆமா சார். அது ஒரு ரிசப்ஷன் அன்னைக்கு.
ஆமா,
எனக்கு
சொன்னீங்க நீங்க.
சாப்பிடாம கொள்ளாம கார்ல வந்தேன். அப்புறம் 8 மணிக்கு இது சொல்லிட்டதுனால, கமிட் ஆயிட்டதுனால சாப்பிட
naturally.
குட் ஈவினிங் சார்.
வணக்கம்மா. ஏம்மா கணத்துல கை வச்சு உட்காந்துட்ட?
ஓட்டு போட போறீங்க.
கை வச்சு உட்காரலாம்.
கணத்துல கை வச்சாச்சுன்னா போச்சேம்மா. ஏம்மா கன்னத்துல கை வச்சாச்சுன்னா என்னத்துக்காரது? நான் என்னத்துக்காரது? நான் தலையில சுண்ட போட வேண்டியதான். ஆரம்பிக்கலாம்ப்பா.
கொஞ்சம் மியூட் பண்ணுங்க. மத்தவங்க யாரு எல்லாருமே ஆஃப் பண்ணுங்க.
அசரீரி குரல் மாதிரி இருக்குது. என்னப்பா ஆரம்பி.
சரிங்க சார். Good evening, everybody. Thank you very much for joining in this 103rd Postgraduate Clinics in Pediatrics of IAP Tamil Nadu. We'll start the day's proceedings with the pediatrician's prayer. But over to our treasurer, Dr. Dakshaini, for the pediatrician's prayer.
குழந்தை மருத்துவனை நிறைந்துதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயுடன் துன்பம் சேர்க்கும் திறன் எங்களுக்கு வழங்கப்பட்டது. எப்படிப்பட்ட சிறப்புரிமை என்பதை பணியுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றவும், நல்லனவற்றை உள்வாங்கவும், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் கருணையும் அருளையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். நன்றி.
Thank you. From this year, we thought that we go for the short cases rather than the full-blown long cases, which we have been doing it for the last 4.5 years. This is part of the presidential action plan of our President Dr. Balashikar sir. Over to Balashikar sir for a few words before we proceed to the program.
Good evening, everybody. I think we are IAP Tamil Nadu is doing a wonderful job in conducting this continuous medical education to sharpen the knowledge of postgraduates. So earlier they were able to listen to the teachers of their own institutions. Now they are able to attend the classes and listen to the experts in the field from all over India. This is the main advantage of this platform. Only one disadvantage is they cannot demonstrate the clinical findings and all. It's a little difficult. Otherwise, this is one of the very, very interesting and innovative ideas which was created by my predecessors, especially Dr. Rajadan mastered in it. And it is being continued this year also. I'm very happy to be part of it. And today we have got a distinguished person, Dr. Anjit Kumar Manoharan. My friend, we have been associated with him for some other work also. He's done so much of work and in pediatric neurology and has been trained abroad in pediatric neurology also. And his concepts are very clear and concise, and I think he will give very sharp and clear-cut points in this discussion of floppy child and involved child with involuntary movement. And Srinivas Sarapati Sollave Vendam, a stalwart teacher of teachers. And I think today we will have a fantastic academic feast, which is served by none other than my parent institution, Madurai Medical College, Institute of Child Health and Research Center. Thank you very much for the opportunity. Well done.
Thank you. Thank you, sir. Thank you, sir. Before we start, couple of house rules, because I said before, we had because of technical issues, we are not able to convert this into webinar. I request all other participants to keep their mic muted all the time. My special thanks to Dr. My teacher, Professor Srinivasan sir, who, in spite of being in US, actually has joined us. And உண்மையா சொல்லணும்னா அவரோட அறிவு தாகம் வந்து இங்க இருக்க யாருக்குமே கிடையாது. கொஞ்சம் கூட கிட்ட கூட நெருங்க முடியாது. A person who has learned so much and still he is interested in listening. In fact, he said that just send me all the links so that I want to just listen and learn. That's what he told me today morning. So that kind of a keen, I mean, absolutely incredible human being. And of course, Dr. Ranjit, whom we are very happy to have here as our teachers. I also request our participants to make sure that their cases finish within 40 minutes of presentation. So each one of them shall not take more than 40 minutes so that we can discuss both the cases. Over to our academic coordinator, Dr. Urgesa Lakshmanan, for taking over the proceedings.
Sorry. Actually, as the secretary told, we have planned this year to be the presentation to be short cases, but the neurology case we'll try to make it as a short case presentation within 45 minutes. And one more thing, actually, we planned this every first week of Friday, but due to Sivaratri, we have to conduct it on the second Friday. But probably from next month, we'll be having it only the first Fridays of every month. So without any much delay, let's go into the case presentation. And I request the participants to stick to the time limits. Karthiban?
Yes, sir. I'll start with the case presentation, sir. Yes, please. A 8-month-old male infant, firstborn out of non-consanguineous marriage, coming from Tirupalai, Madurai, whose informant is mother with good reliability, presented with chief complaints of decreased limb movements noticed since 5 months of age, cough and fast breathing for 14 days. History of presenting illness. Mother noticed the child to have decreased movements of all 4 limbs compared to other children of the same age since 5 months of age. The infant was able to move his arms and hands, but was not able to reach out to objects or able to hold an object. In comparison, the infant was able to only occasionally lift up his knees with little movement of eye, leg, and foot. No history of diurnal variation of weakness. History of cough and fast breathing for past 14 days, associated with chest retraction, associated with feeding difficulties, not associated with post-acute regurgitation of feeds. No history of recurrent aspiration. No history suggestive of congenital heart disease. There's no history suggestive of congestive cardiac failure or cyanosis. There's history of inability to lift the arms above the head. History of inability to reach out and hold objects. History of inability to lift the head from bed. History of inability to sit even with support. No history of difficulty in putting diapers. No history of scissoring of legs, persistent fisting. History of slipping of child when held in arms. No history of squint, abnormal eye movements. No history of facial asymmetry while crying. No history of drooling of saliva. No history of collection of food materials in mouth. History of nasal regurgitation of feeds from 6 months of age. No history of weak cry since birth. No history of drooping of eyelids. No history of involuntary movements. No history of dribbling of urine. No history of seizures, tonic posturing. No history of increase in head size as noticed by mother. No history of increased sleepiness or incessant crying. No history of not gaining weight since birth. No history of fever, vomiting, loose stools, constipation, abdominal distension. No history of pressure sores or ulcers. Past history. History of not attaining head control till 6 months of age, for which the child was taken to a
Hello,
neurologist.
instead of this thing, going further, this thing, I think can discuss
Yes, sir.
the first slide and then second slide why you are asking no, what is the purpose, etc.
Yes, sir.
Dr. Ranjit, you agree with me? Dr. Ranjit? Yeah, because
Dr. Ranjit
for
sir,
every
Ranjit
no,
sir.
you must have reason to say. Yeah.
Dr. Ranjit?
Because we don't because so many no's, many people get upset, so they must tell why, what is the reason and what information it gives, and the order in which you have put it is somewhat different, because you have to go right from the beginning. Some this thing is advanced milestone, some of them are earlier milestones. I think the sequence of your no's are not this thing, you should modify it, but anyhow, that is one suggestion for your examination. But
Yes,
right
sir.
now you can make all these mistakes so that we'll not do it again in examination.
Yes.
Okay. Yes. You agree with me, Dr. Ranjit?
Dr. Ranjit?
So first title itself, you go to the title.
Is there actually for some reason we are not? I
Yeah,
don't think
a
we are.
case of floppy infant. Okay. So you have mentioned that floppy word, but according to your symptoms, you initially mentioned symptom is inability to move the limbs. Okay, a child with paucity of movement of limbs would have been this thing better title rather than saying floppy right away. You have given a indication that you are going to talk about a floppy infant, but from the history, the mother has noticed only inability to move the limbs. Floppiness, of course, comes only after a few of the other questions. You understand what I'm saying?
Yes, sir.
Yeah, because you are given almost
Can you hear me
hint
now?
that, yeah. So when you are telling a particular title, you must tell only what the mother says. So mother has said to you that child is flopping the word she would have used. Child is not moving the limbs very
Yes.
freely like other children. Okay.
Yes.
So this is one suggestion so that
Yes.
straight away you cannot, otherwise they'll think that you know already the case and you are presenting it. Okay, yes.
Yes, sir.
You
Sir,
agree with me,
can
sir,
you hear me
Dr.
now?
Ranjit and other examiners who are here? Because
Yeah.
we
Can you
must
hear me
not
now?
put in a word which is not going to give a diagnosis straight away. Yes. Yes.
Dr.
Do you
Ranjit?
hear me? Yeah. Do you hear me, sir?
Yes, now only.
Yeah.
Yeah.
Ranjit Kumar, you agree with me?
Yeah.
So,
Absolutely agree. Only thing I want to add is like, did we mention about what is the nature of tone even in the
Sir?
Sir, you are not audible. Ranjit, you are not audible.
the title should have been a child who is having difficulty in movement of limbs, okay, or paucity of movement of limbs. That would have been better rather than just putting floppy straight away. Okay, floppy is one thing which we, unless the mother says educated mother, you cannot say that. Okay, so use a word which is used by the mother. I am presenting a child of this age with the problem with the of not moving the limbs as other children do. You understand what I am saying?
Yes, sir. Yes, sir.
Yeah, please. Now you analyze each and everything. Yes.
Yes, sir. So mother initially noticed to have decreased movements of all four limbs compared to other children at 5 months of age, sir.
Okay. Yes.
Till 5 months of age, child was found to have some limb movements, sir. First history I have asked is for diurnal variation of weakness.
No, you
Diurnal
have to be
variation,
very careful about this particular this thing. Are you very sure? Because when the mother lifts the child, 4th month neck control will be there.
yes,
So
sir.
5th month. So she found, even
No,
while lifting, the mother will know whether the child is, having falling off this thing head backwards, etc. Okay. Yes. Anyhow, proceed. Yes. Next.
the first history was regarding diurnal variation of weakness. History of diurnal variation of weakness was asked to rule out congenital myasthenic syndrome, sir. Next, along with the decrease.
What is that one word not associated with the post-tussive regurgitation of feeds? What do you mean by that? I don't understand that.
Sir, after cough, sir.
After cough, what happens?
Poor, associated with regurgitation of feeds, poor coordination between respiration and.
Will regurgitation of feed will be followed by cough, or cough will be followed by regurgitation of feed? What is the thing which usually occurs?
Regurgitation of feeds will be followed by cough, sir.
That is it. Huh?
Yes,
okay.
Sir. Yes, sir.
Right. Okay. Right. So it's correct yourself. No
Yes,
history of just of congenital heart disease. No diurnal variation. Okay. Next slide. Lift the arm above the shoulder. What does it mean from the first line?
First slide to rule out weakness, sir. Proximal weakness.
Proximal
for upper
weakness.
limb, sir.
No,
Is
you have to talk
okay,
about the neck control.
about the distal
See,
weakness. There's no distal weakness in this child.
sir,
Child is
according
able
to the
grasp.
milestones only you have to go because no head control is the first one. Okay, and the child turning over. So from asymmetrical tonic reflexes will disappear. Child will start turning. So those are important before you talk about individual arm lifting, etc. You understand?
Yes,
So
sir.
he is telling, so development history, he will tell, sir. This is
Yeah,
this
that's
may
what
be
I'm
the
saying.
weakness
No,
only.
according to the symptoms also, he should elicit in such a way that he will talk about the child is able to hold the neck. Okay, because the mother will be able to tell when child is being lifted. Okay. Anyhow, this is what the examiner expects, you go standard according to the developmental program because lifting the arms and all comes later. Okay. Yes.
For proximal weakness of upper limb, the question was to lift the arms above the head. For distal weakness, it is to hold the object, sir.
Was it able to hold it?
No, sir.
No. So what is the weakness? Where is the weakness? Where is the lesion? Proximal or distal?
So both proximal distal, according to history, sir.
According to the history.
Yes, sir.
Right. Okay. Right. Go ahead. Previous slide podpa.
Yes, sir. History of inability to lift
Able
the
to
head
sit
from
sit even with the support. It is not even with support. 7 months it will sit with support only. Okay, any child, not only this child.
Yes.
Okay, right? Difficulty in putting diapers. Why there is no history of difficulty? Okay.
No history, sir.
No history of
Followed
swimming
central
legs.
cause, sir.
Okay. Sleeping of child when healthy norms. No squint. Why do you want to ask this squint abnormal eye movements?
Congenital myasthenia gravis or a transient myasthenia gravis is more common to rule out those two, sir.
Okay, then any other condition, floppy?
For abnormal eye movements, we have congenital myopathy, sir. We are all associated with ophthalmoplegia, sir.
Yes, of course. Then
congenital myopathy, congenital muscular dystrophies.
yes. So squint may be a feature in those conditions.
Yes, sir.
But it is never a feature in this SMA. What
SMA,
is
sir.
commonly
Yes,
see the ocular movements are absolutely normal in these conditions. Okay, good.
Yes, sir.
Go ahead.
No history of facial asymmetry while crying, no history of drooling of saliva, no history of collection of food material in mouth. All this history to rule out bulbar weakness, sir.
Okay.
There will be a facial involvement in congenital muscular dystrophy, congenital myotonic dystrophy, or congenital myopathies, which we don't encounter in spinal muscular atrophy, sir.
Okay.
The history of nasal regurgitation of feet from 6 months of age. This is to indicate the cranial nerves involved arising from brainstem. So cranial nerves arising from brainstem is involved in almost all myopathies, sir. Even in spinal muscular atrophy, there is involvement of brainstem nucleus, sir.
So which nerve is affected here?
Here, with nasal regurgitation, I am telling about cranial nerve 9 and cranial nerve 10, sir, which innervates a
Can we
pharyngeal
tell like that? Can we tell this is the nerve it is affected or a group of muscle separated by the nerve, something like that? Because these are all, I don't know whether this is a paralysis will involve different nerves on different times. Okay,
yes,
right?
Yes,
better to say that these functions or these movements are affected.
Yes.
This group of muscles are affected, something like that. Okay.
Yes, sir.
And
Yes,
this
sir.
cranial nerve is involved.
Yes, sir.
Okay. Muscles
Yes.
of mastication, muscles of swallowing, or nerve supply to the muscles of swallowing are affected.
Yes,
Then
sir.
saying that this cranial nerve is particularly affected.
Yes,
okay.
Sir. Yes, sir.
That's better to say like that.
Yes, sir.
Okay, then.
I'll put it. No history of weak cry since birth.
Okay.
No history of drooping of eyelids. This is more specific to myasthenia. No history of involuntary movements in the form of any tremors to rule out some central causes, sir.
What central? What involuntary movement do you expect? Please tell.
Sir, dystonia, sir. Dystonias can be seen in Loeys syndrome, Prader-Willi syndrome.
Okay, then.
Even if any insult to basal ganglia, we'll have involuntary movements, sir. Any hypoxia causing insult to basal ganglia will cause involuntary movements.
Okay. So central causes.
Yes, sir. Yes, sir.
So it may have baby associated with some involuntary movements. Okay.
Yes, sir.
Definitely
Yes, sir.
not the your nerve or muscle or anything.
Yes, sir.
Right?
Yes, sir. Yes, sir.
Right. What about Ranjit Kumar? What happened? Muries?
No, sir, is there, sir? Is there? I just.
Why is not
Can
coming
you
inside?
hear me? Initially, can you hear me now?
Yeah,
Yes,
yeah,
sir.
we can hear you, Dr. Ranjit.
Yeah. Sorry for some interruption at the beginning. So, question to Dr. the presenter.
Yes, sir.
So, did we comment about respiratory involvement in the form of diaphragmatic or intercostal weakness by the history?
They have just mother had mentioned only about retraction, sir, about chest retraction. They did not comment about paradoxical involvement, paradoxical respiratory movements, sir. I don't comment on that.
Never mentioned, no. That's
No,
what's
sir.
important. Yeah.
Yes.
You
Yes.
have told each and every cranial nerve and every this thing, various extrapyramidal system and all, and myasthenia, but that is very important. Okay.
Yes, sir.
Breathing difficulty.
Yeah.
Yes.
So, I absolutely agree with what Sir said. Like, instead of saying cranial nerve involvement for regurgitation of feeds, you say what are all the possibilities when you have a nasal regurgitation of feeds.
Yes,
It is used on the lower motor neuron, right? Starting from the
yes, sir.
nerve nuclei until the muscle end. Muscle
Yes.
end.
Yes.
So all those. Did we comment about any fatigability or fatigable cry or any diurnal variation in terms of weakness?
A diagonal variation of weakness I have commented, sir.
Any fatigability?
There's no fatigue. I have not commented. Yes, sir.
How would you comment about fatigability in an 8-month-old baby?
Like poor suck as the day goes, or a weak cry or weak activity as the day goes by.
So the baby can have a fatigable cry or even a fatigable suck over a period of time.
Yes, sir.
And nicely you have pointed out no history of increased weight gain. I like that point. Why did you specifically comment that?
To rule out Prader-Willi syndrome, sir.
Yeah, that's good to note as Prader-Willi syndrome. Usually, your history in Prader-Willi will not be like inability to move the limbs, as you have highlighted. So I just want the students to understand when we talk about inability to move the limbs, I think that was your major point, I guess.
Yes.
It kind of points towards weakness rather than hypotonia, floppiness. So looks like you are trying to hint towards a peripheral kind of hypotonia, which is a floppy weak baby rather than a floppy strong. When we talk about not weight gaining since birth, it is a central hypotonia, which is floppy strong when the limb activity is very good. And you nicely pointed about this other features. What about any inborn errors of metabolism? Can inborn error of metabolism present with hypotonia, and what will be the etiological clues you typically ask in the history?
Can I add one sentence, sir? Hello? Can I add one sentence? Because, in an 8-month-old child, mother will be lifting the child often. So whether the head is falling backwards or forwards, or it is unsteady, that is very important to this thing in a child. Okay, we have mentioned so many other negative points, but neck unsteadiness and child is ragdoll appearance. When she is lifting the child's head falls back. That is very important. 4th to 5th month neck control will be there. That will give an idea whether there's a generalized floppiness of the axial system and limb system.
Yeah, I think please proceed in view of time. Yeah.
Yes, sir. Past history of not retaining head control till 6 months of age, for which the child was taken to a neurologist. After clinical examination and neuroimaging, child was suspected to have a neurological problem and hence referred to NIMHANS Bangalore. A genetic analysis study was sent from NIMHANS, and after 1 month, the parents of the child were intimated that the child is diagnosed to have a genetic disorder. Child is not a known case of congenital heart disease, seizure disorder, or TB. Currently, the child was admitted with respiratory distress at our hospital. After 6 hours of admission, infant developed respiratory failure and hence was intubated and put under mechanical ventilation.
Just to comment,
yes, sir.
In past history, it is good to highlight any history of recurrent admissions in the past, recurrent respiratory tract infections in the past,
Yes, sir.
any history of chronic drug intake in the past,
Yes.
any history of episodes suggestive of cardiac dysfunction or respiratory dysfunction. That will be the thing which is nice to highlight.
Yes.
Okay, thank you. Proceed.
Antenatal history, mother is a para 1, live 1, and abortion 1. Maternal age of conception was 23 years. The first gravida was a missed abortion, and medical termination of pregnancy was done at 16 weeks of gestation. Periconceptual folic acid was not taken by the mother. Pregnancy was confirmed by urine pregnancy test at 45 days of amenorrhea, and the mother took iron folic acid and calcium supplementation. There is no history of teratogenic drug intake or radiation exposure. Quickening was felt at 20 weeks, where there is decreased perception of fetal movements perceived by mother from 28 weeks of gestation. Antenatal scan was done. It was found to be normal. There was no polyhydramnios or oligohydramnios. There's a history of non-severe preeclampsia diagnosed in mother at 7 months of gestation, and mother was started on antihypertensive medication. There's no history of exanthomatous fever during all 3 trimesters of pregnancy. Weight gain during pregnancy was 13 kg, and there's no history of maternal UTI at 3rd trimester.
Yeah, excellent review of antenatal history. Just to highlight some of the important points, why did you comment about quickening, and what is the significance of quickening in the floppy baby?
Floppy babies, there will be initial quickening where there is a decreased perception of fetal movements. Some, if it is fetal SMA, you'll have SMA type 0, quickening usually will not be felt. And for other neuromuscular disorders, we'll have a decreased perception of fetal movements after quickening.
So you would highlight in red letters, no history of polyhydramnias, which you write it, but it should be upcoming, and no history of antenatal or fetal hypokinesia, which is like decreased fetal movements.
Yes.
Did we see the word breech presentation? Any history of breech presentation?
The child was no, sir.
Yeah, I would like to hear the word
Breech
the breech or vertex, because these are the 3 important things,
yes,
which I also always look for.
yes.
And as you nicely highlighted the teratogenic drugs and other things. What about the antenatal scans? Okay, told to be normal. Okay,
normal,
okay.
Sir.
Yeah, what do you expect in the antenatal scan abnormality in a child with
a floppy infant? Any central cause, we'll have some cranial abnormalities. Otherwise, for peripheral cause, we won't find, other than polyhydramnios, we won't find any abnormalities, sir.
What about presence of contractures? Have you heard of contractures?
Yes, sir. Any congenital myopathies or an SMA type 0, they are associated with congenital contractures, sir. Yeah. Congenital myopathy, congenital muscular dystrophy, and infant SMA type 0, sir.
Yeah. So genetic causes have a prenatal or antenatal onset. So it's very important to delve into antenatal history in much more detail with specific clues. Yeah, please proceed.
The child was full term and delivered by a lower segment cesarean section. Indication was imminent eclampsia. Child cried at birth. There is no details regarding cord length. Birth weight was 3.25 kg, and there's no history of NICU admission. The child was with mother in postnatal ward for 5 days with no history of feeding difficulties, phototherapy for jaundice, cyanotic spells, or convulsions.
Presentation Terilia vertex breach and
Yes, sir. Because the LSCS
that you have to ask actually. So
yes,
that's your task. As Dr. Ranjit told, it's important actually.
Yes, sir.
Okay. Because they don't change in position from a small position to vertex. These children
yes.
floppy. Okay, good. Okay, go ahead.
Yeah, just a quick addition. We would like to hear any fetal bradycardia, any sentinel event at birth, which you nicely highlighted, but still fetal distress, fetal bradycardia can all lead to intrauterine hypoxia, causing floppiness later in life. Yes. And it's nice to highlight any blood cord gas were done or not, and what was the Apgar score available. Only one quick question. What will be the abnormality in Apgar score in otherwise floppy child who did not have any birth asphyxia?
Apgar score should be normal, sir.
What are the components of Apgar score? Quick.
Yeah. Heart rate, respiration, cyanosis, color of the child, movement, tone, and movement, sir.
So in a floppy child, the tone will get a low score. So the Apgar score may be falsely low. So I always look at that. And one interesting history which you can actually ask is any history of uterine hypotonus during the delivery. So this one is normal delivery or cesarean, like LSCS, yeah.
LSCS,
So,
sir.
yeah, sometimes you get, if it is a vaginal delivery, you get a history of uterine hypotonia. That means there was a decreased contractions. What does it indicate? Any clues?
Mother with myotonic mother with
Excellent. Yeah, excellent. Yes. A mother with myotonic dystrophy will have a uterine hypotonus. Yeah. Proceed.
yes. Developmental history. Child attains social smile at 3 months of age. Child start having cooing from 3 months of age and babbling from 5 months of age. Cross motor head control had not yet attained, and bidextrous speech is not yet attained. Child watches mother's face with intent while feeding. So my impression is there's a delay in fine and gross motor development, while language and social milestones are attained appropriate for age. So there is a probable peripheral neurological issue.
ஏன்பா லாங்குவேஜ் மைல்ஸ்டோன் சோஷியல் மைல்ஸ்டோனையும் பெரிஃபரல் நியூராலஜிக்கல் டிசீஸையும் ஏன் சேர்த்தீங்க?
When there is a higher function, social and language are more towards a higher function or central. Those both are involved. We can tell it as a central.
ஓ அப்படி சொல்றியா நீ?
Yes, sir. The social language are intact. So when there's only a motor delay with intact social language, it's less likely to be.
There's no delay in development, so there's no central involvement. Only spinal cord or below. That's what you want to say.
Yes, sir.
All right. Okay.
Sir is right in mentioning that. So instead of kind of trying to localize here, you can conclude as a predominant or isolated motor delay.
Motor delay. Yes. Then intellectual
a predominant or isolated motor delay than trying to rather than trying to localize here.
Yes, sir. Yes.
And I always like to hear vision and hearing as a part of development. So instead of trying to just add one line at the developmental stage itself, although you can elaborate.
Yes, sir. I go to the next.
Vision is all right.
Yes, sir. Vision is all right, sir.
Tell that.
Vision is all right, and child responds to a loud voice, sir. It localizes its eye to loud voice, sir. It does not turn its head to loud voice.
Yeah, please proceed. Yeah.
Yes. Family history. There is a history of abortion along the maternal side of the family. No history of sudden unexplained death among family members. No history of seizures, developmental delay among family members, and there's no history of any neuromuscular disorders in family members.
Nice family tree, but the examiner may like to see a 3-generation pedigree. It looks like a 2-generation. Am I correct?
Yes, sir. Yes.
Yeah. We would like to hear there is no history of myotonia, no history of ptosis, or no history of any history of myasthenia gravis, specifically in the mother.
Yes, sir.
That is important to highlight that.
Yes, sir.
Just make sure you put 3-generation pedigree because the examiners are fond of asking that. Yeah.
Yes, sir. Yes.
Please proceed. Yeah.
Dietary history. Child was on exclusive breastfeeding till 5 months of age. Formula feeding was initiated from 5th month of age. Immunization history. Child immunized appropriate for age. Last immunization at 3.5 months of age. No optional vaccine given. No adverse event following immunization, and BCG scar was present. Contact history. No history of contact with open active case of TB patient.
Next. Go.
Summary. 8-month-old male infant born of non-consanguineous marriage to a mother with non-severe preeclampsia with history of spontaneous abortion in the maternal side of the family was admitted with complaints of decreased spontaneous limb movements since 5 months of age, delayed motor milestones with normal language and social milestones, cough and fast breathing since 14 days with no significant perinatal history, and immunized appropriate for age. The probable system involved is a nervous system with probable etiology directed towards a peripheral cause. Shall I proceed, sir?
Yeah, maybe you can just quickly add no history of any specific cranial nerve involvement or
Yes.
higher muscle functions or
Yes.
autonomic system or sensory or cerebral as one line.
Yes, sir.
And I would still like to hear the word floppiness or hypotonia in your summary also.
Okay, sir.
Somewhere you try to fit in. You said the child is slipping through, right?
Yes, sir.
So probably you can add a floppy infant or somewhere something like a peripheral hypotonia, trying to add that component into your summary aspect also here.
Yes, sir. Yes, sir.
One more important is the condition static, progressive, or improving? You would like to hear that word.
The condition is progressive.
Progressively worsening.
Yes, sir.
That also I would like to hear.
Yes. Yes, sir.
Somewhere you can put it like gradually progressive.
Yes, sir.
We have a hand of Dr. Jalil. Do you have any questions or comments, Dr. Jalil? Okay.
Hello.
So, yes, sir.
Sir, thanks. Thank you very much. May I know the presenters are students? Both are students, MD students?
Yes, sir.
Yeah. Sir, I just wanted to know, being a neonatologist, Sir has asked about the APGAR score, but the expansion of the APGAR score you are telling in a random way. You must tell A for P for G for like that. G is the grimace. The
Yes, sir.
final one R is the reflect. So
Yes,
these five you have to give to each component. And Sir was rightly asking you the tone. So that tone is always -2.
Yes.
And you have not mentioned about the APGAR score because you are stating from the history antenatal, the paucity or absence of quickening. It always, unless proved otherwise, we think in those days, even the ultrasound, absence of ultrasound era, the spinal muscular dystrophy, SM. So this is the anterior horn cells, congenital anterior horn cells. We always think of this quickening, very important. And regarding the development, you have to tell in the order. First in the early child development, even in the workshop, we used to teach it, gross motor, fine motor, and the cognitive and social, and then finally comes the central. Like that, the order is come.
Yes, sir.
So what is the final diagnosis this child? You have not mentioned. It's a floppy infant for evaluation.
Sir, he has not completed the presentation, sir. Only history.
And in the history, sir, the report has been admitted to the NIMHANS. Why it is mentioned in that? In the examination, we are not supposed to mention.
Yes, sir.
Why, sir?
Yeah. So, points well
Okay,
taken, sir.
go ahead. Go ahead.
We don't have much time, so proceed with the examination.
Okay,
Yeah.
okay.
Examination. Child was under mechanical ventilation while examination. Child was awake, afebrile, and interested in surrounding. The baby was lying supine on bed with both the legs abducted, with the lateral surface of thigh and feet touching the surface, with both the hands lying by the side of the body with elbows extended. There was no pallor, icterus, cyanosis, dependent edema, or lymphadenopathy. There were no signs of dehydration and no neurocutaneous markers.
Yeah. Simply, you can say frog-like posture, right? Is it frog-like posture?
Yes, sir.
Yeah. Simply say frog-like posture. Yeah.
Yes.
Okay.
Vitals, heart rate was 110 per minute, regular rhythm with normal volume and not associated with any special characters, no radial or radiofemoral delay, and was felt equally in all accessible peripheral vessels. Respiratory rate, the child was currently under mechanical ventilation, and saturation was 98% under mechanical ventilation. Capillary refill time was less than 2 seconds. BP was 80/50 in both right upper limb and left lower limb.
Yeah, although you highlighted mechanical ventilation, was it minimal settings or maximal settings?
Minimal settings, sir.
Yeah, because if the patient has only neuromuscle weakness, nothing else, you just require minimal settings.
Yes, sir.
Some LRI also.
Yes,
Some
sir.
LRI also, sir. Came for difficulty in breathing only. Okay, carry on.
Yes, sir. Anthropometry, the current weight of the child is 7.6 kg with the expected weight of 8 kg, and the child's centile lies between 0 and -2. Height is 72 centimeter against 71 centimeter, and head circumference is 43 centimeter, which is expected head circumference for the
height சொல்றேன் இந்த சைல்டுக்கு போய்
length, sir. Head to toe examination. Head is normal in shape and size. There's no low set ears. There's no low hairline. No coarse facies. Anterior frontal is wide open, depressed and falsetile. Eyes are normal with no hyper or hypotelorism. No prominent epicanthal folds. No cataract. No drooping of eyelids. Lips and philtrum are normal. No high arched palate. Tongue fasciculations are present. Neck is normal with no loose folds of skin around the nape of neck. No chest wall deformities. There is undescended testis. Hands and feet are normal with no contractures. No syndactyly, polydactyly, or clinodactyly. No neurocutaneous markers.
Did you examine properly? It is really undescended testis or retractile testis?
Undescended testis, sir.
Sure.
Yes, sir.
Still it is undescended.
Yes, sir.
Okay, surprising.
Systemic examination.
Of the presenter.
Yes, sir.
I would like to hear as a technologist use words like bright, alert faces.
Yes.
Is there any bell-shaped chest?
No, sir.
Is there
No,
highlight? Is there any bell-shaped chest?
Yes, sir.
All babies on ventilator, I understand, but still, how was the movements of the respiratory muscles? Although the baby is on ventilator, we
It was
understand.
regular. There was no paradoxical movements of chest.
I would like to hear a word, any suggestive of myopathic phases, one word.
Yes,
Under
sir.
that band, you can describe what does myopathic phases mean. But still, you highlight that you look for a myopathic phases. Yeah.
Yes, sir.
Then move to the next slide. You highlighted tongue fasciculations nicely.
Yes, yes, sir.
Just move to the next slide. Yeah. Undescended testis you highlighted. Unilateral or bilateral undescended testis?
Sir, left undescended testis, sir.
Yeah. Also, I think it's important here.
Okay.
Yes,
We highlighted no issue of contractures. What about the spine and cranium?
Spine cranium normal, sir. I've brought it in the CNS examination, sir. Cranium, normal in shape with no dolichocephaly, sir.
Yeah. So, see, we have to, as a pediatric PG, you should highlight the treatable causes of hypotonia also. No signs of rickets, or no signs of vitamin B12 deficiency. These are some of the treatable causes. I think your examiners like to hear those words. Just highlight no signs of nutrition, B12 deficiency, rickets.
Yes.
Please proceed.
So, central nervous system examination on higher mental function. The baby was alert and interested in surroundings. Baby responded to auditory stimuli. No tonic posturing or vacant stare. The other functions could not be tested. Regarding cranial nerve examination, cranial nerve 1 could not be tested. Cranial nerve 2, bilateral pupil 3 mm equal and reacting to light, fixes and follows light. Direct and consensual light reflex were intact in both the eyes. Bilateral fundus were found to be normal. Cranial nerve 3, 4, and 6, extraocular movements found to be in full range. There was no strabismus, nystagmus, or ptosis. Bilateral PRL present. Cranial nerve 5, facial sensations were intact. Corneal and conjunctival reflex were found to be intact. There's no facial asymmetry regarding cranial nerve 7. Cranial nerve 8, startle reflex was present. Infant was able to look towards loud noises. Cranial nerve 9 and 10 could not be assessed because child was in a mechanical ventilation. Cranial nerve 11, child was unable to turn the head side to side. Cranial nerve 12, tongue fasciculation was present with no tongue atrophy or hypertrophy.
Just a quick comment. We don't have to do a conjunctival corneal reflex in a bright alert child.
Yes.
Just the other thing is, it is an endotracheal intubation or nasotracheal intubation?
Endotracheal intubation, sir. We tried nasotracheal intubation, but child did not tolerate nasotracheal intubation.
Is it possible to do that reflex or not?
Because it was an nasotracheal, because it was an endotracheal, I can still do.
You can still try doing a gastroesophageal reflex, or you can also comment what was the cough reflex or gag reflex when the suction was carried out.
So reflex was intact.
So those kind of indirect clues you can
Yes.
highlight to the
Yes.
examiner.
Yes, sir.
Yes.
There's a video.
I want to know whether you examined the child before the child went into this ventilation or later.
Sir, after, sir. Child was
When the child is
intubated.
already on ventilation.
Yes, sir.
Because if not, if a child is not on ventilator, you have to do 3 maneuvers in a floppy baby.
Yes, sir.
Especially
Yes, sir.
with fasciculation. What are
Yes,
the 3
sir.
maneuvers you have to do by
Sir,
holding the child?
Ventral suspension, dorsal horizontal response, and vertical response and traction response, sir.
And pulling the child, yeah, traction
Yes, sir.
response. So,
Yes, sir.
because of course the child is on ventilator, we will not be allowed to do. But whenever you find the child with floppiness or generalized floppiness and this thing, and this is what is important. 3 important to find out now. The 3 which you already mentioned. Good.
Yes, sir. There's a vasculation. Bulk was found to be equal on both sides with no wasting. Tone was decreased in all 4 limbs. Ventral suspension, dorsal suspension, and traction response could not be elicited in this child. Power, the power of upper limb was 2/5. The shoulder power was 1/5. Elbow bilateral was 2/5. Wrist was 2/5. Hip and knee it was 1/5 in both the sides, and ankle 2/5. Sir. Reflexes, all deep tendon reflexes along with plantar reflex was absent in this child. Sir. Primitive reflexes, oral reflex, sucking, rooting, snout reflex could not be elicited. Motor reflex could not be elicited. Startle reflex was present. Grasp reflex was absent in this child. Asymmetric toning neck reflex was absent in this child. Parachute reflex could not be done in this child. Sensory system, pain, touch sensation was intact in this child. There is no cerebral or autonomic signs. Cranium head size was normal with anterior frontal 2.5 cross 2.6 centimeter was open. Posterior frontal was closed. No sutural overriding or abnormal separation. Spine was normal with no sacral dimple, tuft of hair, swelling in sacral region. No joint contractions or callosities. Respiratory system, chest wall and thorax were found to be normal in shape. Bilaterally symmetrical. Child was under mechanical ventilation and there was bilateral conducted sounds on auscultation. On CVS examination, S1, S2 was heard with no murmur. Her abdomen was soft, not distended with no organomegaly and bowel sounds were present.
Right. If this child had hepatomegaly, what will you think?
I'll suspect cerebral hepatorenal syndrome, Zellweger syndrome, glycogen storage disorders, acid maltase deficiency, Pompey's.
Excellent. I think Pompey should be the top difference. Yeah.
The examination of the mother, there was no grip myotonia, percussion myotonia in mother. There's no abnormal or myopathic facies. There's no ptosis. There's no hyperextensible joint, no joint contractures, or no palpable peripheral nerve.
Excellent.
Summary, an 8-month-old male child with uneven full antenatal and natal history, born of non-consanguineous marriage with family history of spontaneous abortions, was admitted with complaints of floppiness, decreased limb movement since 5 months of age, and fast breathing for past 14 days. On examination, child was alert with hypotonia of all 4 limbs with weakness, absent deep tendon reflex with tongue muscle fasciculation and respiratory distress.
So nice. So I always like to hear 3 words. Your 1-line physical diagnosis, 1-line localization, and 3 etiological possibilities.
Yes. Physical diagnosis, you have a hypotonia with weakness of all 4 limbs, sir. Localization, the power is more decreased in the proximal vessels when compared to the distal muscles. You have an elbow, wrist, and ankle with an increased power and compared to shoulder.
We don't have much time. So just one word.
Yes, sir. So
physical diagnosis. Floppy infant with peripheral hypotonia.
Yes, sir. With a floppy infant with generalized hypotonia with predominant proximal compared to distal weakness, and tongue fasciculation. The probable site of involvement can be an anterior horn cell involvement, sir. My differential diagnosis are: number 1 is spinal muscular atrophy of infant type, number 2 is congenital myopathy, and number 3 is congenital muscular dystrophy, sir.
Yeah.
Why with fasciculations you want to consider muscular this thing, myasthenia gravis? Once fasciculation is there, almost you fix the diagnosis.
Yes, sir. Spinal muscular atrophy.
I think well presented, sir. In view of time, I think, do you have some 2-3 minutes for discussion, or should we just proceed to the next? Okay,
He
so
can tell one word, no, 2 sentences about this thing,
Yeah.
management.
oh,
What is
so
the
doc-
current management available for this thing?
so if you are allowed to do only one blood test other than the genetic test, what will you do?
One test.
You have the possibility of doing only one blood test other than the genetic test. Which one would you choose in this baby to do?
CPK for congenital muscular dystrophy, sir. That
Yeah.
will rule out congenital muscular dystrophies.
Yes, but you have to specify MB, MM, total. What exactly would you order?
CPK MM, sir.
I always write CPK total. That is the one which is typically elevated in muscular dystrophy. So suppose the CPK comes back elevated. Suppose, would you do a nerve conduction EMG?
Yes, sir.
CPK, no, listen, CPK
CPK
back
elevation
elevated.
means an acute muscle rhabdomyolysis. So our diagnosis will shorten towards muscular dystrophies and those myopathies with rhabdomyolysis, sir.
So you don't have to do, you don't do EMG. Okay. So CPK back as 210 international. So what is your, what does it fit into this 1, 2, 3, 4?
Sir?
CPK comes back as 210.
It come towards spinal muscular atrophy or congenital myopathy, so it's not that elevated.
Yeah, you are still, your number 1, number 2 is still possible. Okay.
Yes, sir.
So last question. For the genetic confirmation of SMA, what exact test would you order?
Multiple, say MPLA, sir. The test is called as MPLA.
So it's called MLPA.
MLPA, sir.
Multiplex ligand probe amplification. MLPA for all the exons of SM1 gene, including the copy numbers for SM11 and SM12. Because we are in the era of genetic treatments. So I just want to highlight your clinical exome sequencing may not pick up the SM1 deletion.
Yes.
So that's the importance of ordering a deletion study, which is MLPA. So last question, name 3 newer treatments for SMA.
The one which is now followed is antisense oligonucleotide nusinersen, sir. That is one. Then we have a viral vector, sir. Omnisense abipavec, sir. That can be given as an oral drug, sir, to increase the entry of exon 7 into the SMN gene. This diplem is another drug which can be given as intrathecal drug, sir.
Yeah, so the famous 16 crore drug is called Zolzenma. Okay, sir, well presented. Congratulations.
Thank you.
Any other comments, Vasan sir and Bala sir?
This is one more case, no?
Yes.
Shankar says there is no question, I think. Their voice is not heard, sir. No, you're muted. Dr. Balashankar, you're muted.
Please go to the next case, sir, please.
You can go to the next case.
Yes, sir. Yes, sir.
Who is presenting?
Dr. Naveen Kumar.
Dr. Naveen, now Dr. Naveen is presenting, sir. Dr. Naveen?
Yes, sir.
So yes, sir, we are sharing. Sir.
Yeah, please proceed, Dr. Naveen. We have 30 minutes.
Okay, sir. Sorry. 2.5-year-old female child, second born out of non-consanguineous marriage, developmentally normal child, right-handed, brought to the casualty with complaints of abnormal movements of face, upper and lower limbs since 6 months of age. History of presenting illness. The child was apparently normal till 6 months of age. Then she had history of abnormal movements involving all 4 limbs, face, mouth, aggravated by efforts activities, not occurs during sleep. The movement was not associated with the loss of consciousness. The frequency of movements was from 4 episodes per month at 6 months of age to 5 to 6 months per day in the past 1 year. However, not hindering regular activities. This is a video of the child, sir. Sorry.
Nice video you have taken. Yeah. Same child?
Yes, sir. Same child. There is no history of abnormal eye movements or
Yeah.
degradation.
So, Dr. Naveen, before we go back, just go back to the first slide. Little bit more elaboration is required, I guess. What was the type of onset I would like to hear? Is it an acute onset, subacute, chronic, gradually progressive, insidious onset?
Insidious onset, sir. Gradually progressing, sir.
Yes, that's very
Frequency
important.
of
Yes.
movement was gradually increasing, sir. At 6 months of age, there is only 4 episodes.
Was the onset spontaneous, or was it preceded by a prodromal illness or some form of a precipitating factor like a febrile illness or some
Yes.
metabolic insult? It's very important to hear that.
It is continuously occurred, sir. No.
Yes. Then, normal till 6 months of age, developmentally. But that's what you're trying to convey. Normal.
Yes, sir.
Is normal, correct?
Yes, sir.
Frequency, aggravation, and this thing. It is very important to highlight the quality or the nature of the movement in the history itself when you present in your exam. Like, what word would you put to highlight the quality or the nature of the movement? Because in your slides, the quality or the description of the movement is not there. This is the word you want to choose.
Involuntary movement, sir. It was rapid and purposeless, not symmetrical, not jerky movement, sir.
Yeah,
Anything
so
else,
involuntary,
any extra point in
rapid.
this thing? Movement? Did it affect the child drop the bottle in the hand? Or
No,
did
sir.
the child fall down?
No, sir.
Anytime?
The child was normal.
That is very important to mention. It is not, child was able to stand. Child has not fallen. Child was also holding the bottle. It has not dropped. Yeah.
And also dancing or flowing quality.
Yes, sir.
There was a flowing quality in the movement.
Yes.
Please proceed.
Okay. There is no history of abnormal eye movements due to patients swaying of hands during walking. No, there is no history of stiffness of limbs or abnormal posture. No history of altered sensorium. No history of malaria or joint swelling. No history of blurring of vision or vomiting. No history of viral exanthematous fever. No history of loose stools. No history of trauma. No history of loss of weight. No history of any drug intake. No history of jaundice or bleeding manifestation. No history of development delay. No history of difficulty in lifting head above bed. No history of difficulty in turning side to side bed. No history of difficulty in perceiving sensation of class. No history of sweating or flushing of skin. No history of bowel or bladder disturbance. No history of visual disturbance. No history of deviation of angle of mouth. No history of drooling of saliva. No history of difficulty in closing both eyelids. No history of difficulty in swallowing. No history suggestive of other cranial involvement.
So, Naveen, it's nice to put your negative history into 4 groups. First group is history of presenting illness, which highlights your current complaints.
Yes, sir.
Next group, what we call as is neuro axis, which covers from the higher mental function till your cerebral or autonomic system. And next groups comes your etiological clues. Then the last group comes your comorbidities. What I see in your slide, it's all mixed up. Drug intake is coming at the top, bladder bubble is coming. So it's nice to box it.
Okay,
The
sir.
group.
Past history, not in only case of congenital heart disease or type 1 DM, no history of previous admissions. Antenatal history, spontaneous conception, non-consanguineous marriage, booked and immunized. All 3 trimesters are unmeaningful. Antenatal scans are normal. Took iron and folic acid tablets regularly. No history of recurrent abortion. Natal history, full-term LSCS, birth weight 3 kg, cried immediately after birth. No history of NICU admission. Immunization history.
Well, hold on. This is the
But you
most
mentioned the
important.
milestones are normal for this age.
Yes, sir. Development in normal child.
That is very important. Yeah.
Which is the most important history which you as a pediatrician to take in a birth history child who
Sir.
pregnancy. This is the most important of all.
Sir, it is not audible.
Not audible, sir.
Did you hear my question?
No, sir.
Which is the most important postnatal history you should take in any infant presenting with coiform movements?
What you're thinking?
Yes, sir.
He have given a very apt statement. Newborn child. What is the important history with coriform movements? Also with coriform movements. Which condition you will think of? Which symptom?
Asphyxia.
Any history of postnatal jaundice, kernicterus, bilirubin-induced neurological discomfort. Often this gets missed even in this stage in Tamil Nadu. You should specifically ask that question. Yes.
Immunized as per schedule. Diseases are present. Last vaccination at 1.5 years of age. Development milestones attained appropriate for age. No history of similar complaints among family members. Summary: 2.5-year-old child, second born, development in normal child of non-consanguineous marriage, presented with abnormal movements of involving face, upper and lower limbs since 6 months of age with no significant past and family history. My probable diagnosis is movement disorder, probably mixed form of chorea and dystonia, which is paroxysmal in nature.
Can you hear me?
Yes,
Yes, sir.
So little bit would be surprised to hear normal development with such movement disorder. What about the fine motor movement in a 2.5-year-old child? Is she able to hold a pen, able to draw a circle or copy, or what happened to that fine motor?
Able to scribble, sir, and able to copy circle.
Even with this movement?
Movements are occasional only, sir. Between the movements, child was normal, able to scribbles and copies circles, sir.
Okay. And you put the word paroxysmal. Can you please elaborate what do you mean by the word paroxysmal? And we haven't heard that paroxysmal T in your history so far. What do you mean by paroxysmal?
It was like occasional only, sir. Any movement that is occasional, which is increased stimulation, is sudden onset only, sir. Occasionally not continuous.
So from what I am hearing, you want to say it is not continuous. It is not present continuously. It is paroxysmal. That means sudden, triggered by some kind of a phenomena, and it lasts for some time and stops. And in between, the baby is completely normal. That is what we call as paroxysmal, or sometimes we refer that as episodic. Is that what you are trying?
Yes, sir.
So, just for a next level discussion, when we use the word paroxysmal movement disorder, we have two terminologies: kinesogenic, non-kinesogenic. Kinesogenic means that event was triggered by a movement, like a volitional movement, or getting up from a sitting posture or something. Non-kinesogenic means it happens on its own.
Okay, sir.
And any worsening with fasting state or starvation or febrile intercurrent illnesses?
No, sir.
What is the significance of this question? If I may ask you.
Metabolic causes, sir. Maybe hypoglycemia can cause. Viral examiners, fever, varicella,
No.
cause.
Have you heard of GLUT1 syndrome? GLUT1 deficiency syndrome. Have you heard of that?
Yes, sir. Neurological disorder. It's a GLUT2 for
GLUT1 disorder is affecting the gene responsible for transmitting glucose into brain. So that gets fasting state. Yes, proceed.
Mental examination. Child is alert, awake, afebrile, no pallor, no icterus, no cyanosis, no clubbing, no ventralized lymphadenopathy, no pedal edema. Child head size normal, no microcephaly, no facial dysmorphism, no skin rashes, no cave ring, proptosis or telangiectasia. Oral cavity, dental caries present. Ears, throat, extremities normal, no spider neving, palmar erythema, no eczema. Spine was normal. Pulse rate 108 per minute. Respiratory rate 25 per minute.
Hold on. Any signs of hypothyroidism?
No, sir. No signs
What
of
are the signs of hypothyroidism? What are the signs of hypothyroidism?
Dry skin, sir. Hypotonia. Coarse facial features. Intolerance to heat, sir. Macroglosia.
So, do you know why did we ask about hypothyroidism? What is the link?
If child has hypothyroidism, there is a tremor will be there.
No. So here we are looking at chorea, right? So there is a condition called benign congenital chorea due to a specific gene mutation, which can be associated with hypothyroidism. It's called Yeah. Proceed.
Higher function child was alert, speech clear, sleep pattern was normal, right-handedness. Cranial examination was normal. Spinomotor system, bulk equal on both sides, tone was normal. Power more than 4/5.
You quickly went.
Sir?
So it's not audible, sir. Sir?
In a child with chorea, what will you look for oral cavity?
Sir. Darting sign, sir. Darting tongue. Child unable to protrude, sustained protrusion of
Yes.
tongue, sir.
Correct. Proceed.
Deep tendon reflex 2+, sir. Superficial reflex, corneal conjugate reflex normal, abdominal reflex present, bilateral plantar flexor. Sensory system, pain, touch, temperature able to feel, tactile localization, 2-point discrimination, complex sign could not be tested. No cerebral weight was normal, spine cranium was normal, no meningeal signs. Abnormal movement which is involuntary, rapid, purposeless, non-symmetric, non-jerky movement, sir. Other system examination was normal, sir.
It's also good to mention which all the body parts which are involved and distal more than proximal. Again, you highlight the nature or the quality of the movement and any other associated movement disorder. As you said in the beginning, mixed movement. So it's also good to highlight you didn't see some other movements like myoclonus or athetosis or dyskinetic movements or something like a hemibalismus.
No, sir. There is movement started only proximal, that progress to distal, sir.
Yeah. And also it's good to highlight, did the movement get worse on posture, action, or resting? What was that?
So it spontaneously resolved, sir. It does not worsen with activities or posture or wrist, sir.
What is the gait? The child is walking without falling.
Yes, sir. Between the attacks, the child was able to walk, sir. Gait was
When
normal.
when the child is normal, child is not falling. Even when the child was standing, child was not falling. Nobody was holding the child. Child was having abnormal
There is
movement.
fall at the end of the attack, sir. Each
Okay.
attack.
Okay.
Summary. 2.5-year-old female child, second born non-consanguineous marriage, presented with abnormal movements, face, upper, both lower limbs since 6 months of age, with no history of drug intake, no significant past family history. She was developmentally normal child. Her general and systemic examination was normal. The movements were involuntary, purposeless, rapid, and paroxysmal, non-symmetric, not jerky. I would like to differentiate diagnosis, sir. Benign hereditary chorea or paroxysmal, non-kinesogenic dyskinesia, sir.
So before that, it's good to go by the algorithm, right? Physical diagnosis, localization, and then etiology.
Okay,
That is the route we should take. What is your physical diagnosis?
Movement disorder, sir.
Generalized focal acquired congenital Progressive, non-progressive.
Which is generalized non-progressive, sir.
Generalized.
Which is non-progressive.
Acquired or genetic?
Sorry, it looks like congenital, sir. Genetic cause. Age 2.5 years, sir.
Progressive, non-progressive. Progressive, non-progressive.
Non-progressive, sir.
Yes. Okay. Then what is your localization? Okay. I'm asking some questions. Tell me, where do you localize? Hemibalismus. Did you
Substantia
hear hemibalismus? How do you localize?
Substantia nigra, sir. So it's not audible. So it's not audible, sir.
Has the child been taken to a hospital and they had given any treatment?
Yes. Yes, sir. Treated with a haloperidol and clobazam, sir.
Was there improvement?
Yes, sir. Activity is decreased, sir. Attack
The
was
hyperactivity and abnormal movements are reduced.
reduced, sir.
Intensity. Ranjit Kumar is not available.
Yeah, I'm here, sir. Am I audible?
Yeah. Now you are audible, sir.
Just quickly to highlight, myoclonus can be cortical, subcortical, peripheral, or even spinal. Hemibalismus, subthalamic nucleus. All the other, that is your chorea, athetosis, and dystonia, is basal ganglia. So basically, Naveen, we are like to hear the word bilateral basal ganglia involvement because it's a generalized coliform movement. Is that okay? Is that clear?
Okay, sir.
Then comes your etiology, like what you are highlighted. Is there a possibility of a metabolic condition? Inborn error of metabolism? Yes or no?
Sir,
Yes
this
or
child
no?
not associated with no, sir.
So, have you heard of a group of condition called neurotransmitter disorders?
No, sir.
Disorders? No, I give different diagnosis of movement disorder of transmitter defect here. Will you consider mitochondrial disorders?
Ranjit, your voice is breaking.
Neurotransmitter, did we hear that? Neurotransmitter disorder as one differential diagnosis?
Yes, sir.
Yeah.
I
Will
have
you
heard
consider
about it, but no
mitochondrial disorder as
details are
one?
known.
Will you consider mitochondrial disorder as one category?
Yes, sir, but less likely, sir. Child was associated with a seizure.
Yeah, mitochondrial disorders are very broad heterogeneous group of disorders. Can present with myriad of Although it seems less likely because we don't have other clues like metabolic decompensation or neuropathy or sensor neural deafness or failure to thrive, I would say we should still keep that possibility also.
Yes.
And will you still consider kernicterus sequelae Wilson disease, which are the top differential diagnoses in pediatrics? Have you totally ruled out, or what do you think?
No history of neonatal jaundice, sir. Child was not admitted in ICU, sir. That is less likely to pass.
Yeah. And what about your will you consider Wilson disease or not?
No, sir. No hepatic involvement, sir. No family history of.
Not have a hepatic involvement.
Yes, sir. No family history also, sir.
Most important pointer against Wilson disease, very early onset. Neuro Wilson almost always present only after 3 years of age. Okay.
Okay, sir.
Which is the
Sanjeev,
nutritional.
will you tell about how to go about investigating this child? What investigations will give a final diagnosis?
Yes, sir.
First to rule out metabolic causes, sir.
So the first thing I would. Yeah. So Naveen, how will you evaluate this baby?
Routine investigation, metabolic cause first to be ruled out, sir.
Yes. So what next?
Thyroid status.
What next?
Thyroid status, sir.
What is the next test you would do?
ANA, sir.
Sorry, I didn't hear you. What is the next test you would do?
Thyroid function test, sir. Next, imaging MRI brain to rule out space occupying lesion or any structural involvement, sir. Basal ganglia involvement.
Okay, next.
To rule out C, sir, EEG, sir.
Okay, next.
Metabolic screening like TMS, sir.
Okay, anything else? If none of these are giving you any specific clue, what will you go for?
Genetic test, sir.
Yeah, what kind of genetic test you would choose?
Whole exome sequencing, sir.
Yeah, excellent. Sir, do you hear me, sir? Srinivasan, sir?
Yes, I can hear you. I can hear you.
So the first step, sir, as Naveen rightly pointed out, I would do an MRI brain and MR spectroscopy to rule out any structural or the metabolic cause. If
Here
that
he
is
has mentioned anterior. Yeah, here he has mentioned anterior two-thirds of superior sagittal sinus replaced by partial pad veins, and EEG is abnormal. Any interpretation, sir? How do you interpret this?
So the MRI finding looks unrelated finding, sir. That is more like
that's unrelated because I was first time hearing anterior two-thirds replaced by pad veins. So something
that
I
is
was wondering
unrelated.
what is the importance. Okay.
EEG abnormal, I would definitely take it with a pinch of salt. The interpretation. In movement disorder, EEG is typically normal. So I would really like to see the EEG report. Often reporting by adult neurologists may come back as abnormal. I am sure you would know that. So we need to really be more. Yeah. So I would take it that with a pinch of salt. And as rightly Naveen has pointed out, a metabolic workup, including your glucose, lactate, ammonia, and tandem mass, is often indicated. This condition, specifically thyroid, should be looked at because he nicely put that benign hereditary chorea can be associated with hypothyroidism with a specific gene. And if none of these are negative, So, all of these are negative. Sometimes we go for a lumbar puncture, CSF lactate, CSF amino acid profile, and CSF neurotransmitter assay. This was in the pre-genetic era. But now that we are living in the era of genetics, we often tend to go for whole exome with or without mitochondrial gene sequence. In around 70% of cases, that clinches the diagnosis. So, is that clear, sir?
Yeah.
So, in terms of therapeutic trial, Naveen, what are the two therapeutic trials which you will carry out in this child? Therapeutic trials.
Any specific drug?
Dopamine receptor antagonist, sir.
Naveen, there are two therapeutic trials which should be considered. What are those two therapeutic trials? Any child presenting with unexplained movement disorder, like a
Beta
dystonia
blockers,
or dysphoria, a DOPA
we can
trial
try
is
beta
warranted.
blockers.
No. Two trial. One is a DOPA trial, which you should try.
L-DOPA responsive.
With yes. The other thing is which responds with carbamazepine actually. So these are the two trials which you should do.
Okay, sir.
What
I
is the
will
second
say
one, sir? It was
diagnosis.
voice was breaking. What is the second one you mentioned? L-DOPA responsive. Then
Carbamazepine, sir.
The condition successful clinic design is we give carbamazepine.
okay.
We diagnose one in this case.
It looks like we have lost the audio from Dr. Ranjit again. Srivan, sir, anything else to conclude, sir, before?
Yeah. Actually, this is a very, this thing, very, I think what he wanted to tell is very important because neurotransmitter, I have heard some one or two meetings which, in pediatric neurology, there is so much of advances in neurotransmitter, this thing, but of course, voice is breaking and we couldn't hear what we are telling the second thing. One is L-DOPA responsive dyskinetic disorders, and the other one we couldn't hear because it was breaking and stopped. Anyhow, you can this, yeah. So he can
What
only
was
solve
the
this
diagnosis
problem.
in this case? Did you get a diagnosis?
Have they gone to any specific place for investigation and treatment? And any neurology consultant, pediatric neurology consultant, they have gone?
Yes, sir. They diagnosed as paroxysmal non-kinesogenic dyskinesia. Separation diagnosis and genetic analysis. Genetic analysis report awaiting, sir.
They have sent it?
Yes, sir.
They are waiting. Okay.
Nice.
Yeah. So nowadays everything genetic analysis only will finally give the answer. Okay. It's a very interesting case. Yeah. So I think, of course, you can organize,
Yes, sir.
by our this thing on movement disorders and dyskinetic disorders. Lot of advances have happened and so many new conditions have come. So Ranjit can take it because I have listened to recently 3 talks on this. So much of advances have happened which are not still in Nelson. So in case you have this thing, we can
Yes,
ask
sir. We can
them
plan something, sir.
advances in this thing, Yeah, there are in Tamil Nadu itself. There are so many neurologists now who have done very good studies. Yeah.
Yes, sir.
We are getting more cases. Yeah.
Yeah. So I might have missed. Is there a proven diagnosis in this case, sir?
Sorry, Dr. Ranjit. Again, the second drug. Am I right? Is it carbamazepine you wanted to give a trial? Is it?
Sir, there is a condition called paroxysmal kinesogenic dyskinesia,
Okay.
which is usually triggered by some action, like getting up from sitting posture. The child will have this kind of a dyskinetic movement, which responds very well to carbamazepine.
Okay.
So the gene name is called PRRTG. So these are all picked up by genetic diagnosis.
I think I listened to one of your talks on dyskinetic disorders, Dr. Ranjit.
Yeah.
I remember, I think so much advances happened. I asked Tirumurugan just now for you to give a talk on the recent advances in movement disorders. Okay. Recently in Delhi platform, I attended this thing. It was very interesting. They presented some 6 or 7 cases, and
Yes, sir.
they were interesting. Yeah.
Yes.
They are not still in textbooks. I think it's important that you people keep us informed.
Yes, sir. Quickly, sir, do we have a proven diagnosis? Sorry, I'm asking again, like this case.
No, sir. Genetic report awaiting, sir.
Okay, excellent. Okay. Okay, nice presentation. Sir, I am happy to do both movement disorder as well as epilepsy in future, in any time.
Yeah. Because
Yeah, we'll
I
plan
have listened
something.
to you once earlier, and we would like to listen to that is quite a few 2 or 3 years back. I think it's worthwhile listening and learning about updating the movement disorders. Thank you, sir.
Thank you, sir. Thank you very much.
Thank
Both the
you.
presenters, I thank both the presenters, Dr. Karthipan and Dr. Naveen, for the very interesting cases in neurology. My special thanks to Dr. Rajkumar for getting his speeches presented, prepare these cases. Dr. Rajkumar, would you like to comment anything, or would you like to add anything?
Thank you, Rajkumar. Please keep us informed about the final diagnosis of this case.
Raj? Anybody else would like to make any other comments or any discussion regarding this particular case? Any other points before we close the?
Anyhow, we have to appreciate the presentation and presenting students. And of course, if further enlightenment has occurred after this thing, they can let us know subsequently. What is the final diagnosis?
Yes, sir.
Okay. Thank you very
Once
much.
again-
I would like to thank everyone, Dr. Murugesh Lakshman, Dr. Balashankar, Dr. Rajkumar, my teacher, Professor Srivasan sir, Dr. Ranjit, for this very interesting case discussion. My apologies for the technical snag we had with this not being webinar, but I think we still maintain the decorum. So thanks to all the participants. Hope to see you again in future. Thank you very much. Good night.
Thank you.
Appreciate the students for the nice video clipping of the movement disorder case. It enlightened us so much. Yeah.
Thank you. Good night.
Thank you, sir. Nice presentations. Congratulations to IAP and both of you.